Hello there, my name is Gino. I'm the research officer and sepsis lead for the London Clinic. Question for anybody who might actually kind of know the answer, and it's to do with, is the, I suppose, just try and get the right words, the thoughts of anti-vax, is that actually a factor in managing sepsis and including education, or is it not actually, it's a bit of a red herring?
I mean, I don't mind saying something about that. So there's another conference going on next door, which is Infection Control, IPC. So the bedrock of what we do in infection and sepsis management has to rely on good IPC, doesn't it? So I think vaccination is part of that. So if we don't do the simple stuff well, it's going to make it really difficult. We saw this in COVID, people that were vaccine hesitant, who were desperately ill coming to critical care. Then we had to try unproven technologies and medications on them, which strangely they were quite happy to accept, but didn't want to accept a highly proven approach. So I feel quite, it's critically important, it's part of our advocacy that we get out there, we teach IPC, we teach the importance of vaccines, and then, given all of that, then we do what we can for the important things that we try and do for. And if you look at the disparities around the world, if you look in sub-Saharan Africa, that the shocking rates of sepsis and the poor outcomes partially are related to poor IPC.
Yeah. I think earlier was talking about pertussis now causing infections we haven't seen for many years as well.
Yeah, thanks.
That's the question. Yeah.
Hi, my name is Emily. I'm one of the sepsis specialists at the Lister Hospital, Eastern North Herts. My question's for Patrick, actually, about PSP. Is there any instance, and please forgive my ignorance because it's quite a new concept to me, is there any instance in which it could be produced by something other than sepsis in sort of a red herring sort of way?
Could I ask my medical director, who's actually here in front of me, to answer that question?
Who's the medical director?
Soraya.
If you pass the mic, there you go.
Sure. As Patrick mentioned, this is a protein that is produced by the pancreas. So we have seen, for example, for pancreatitis, that the PSP might raise even if the patient will not develop a sepsis. But PSP can be used for level of severity of the pancreatitis. So it can be used and as well for pancreatitis concerts, where we know that the pancreas is also upregulated and might have an impact.
It's just regarding your kind of new technology. Are you looking to trial it in certain hospitals? Are you?
Oh, so this is the gentle reminder that my last pitch, actually, to all of you would be to have said, we're of course open to trying this in the UK, and we'd be very happy to engage with half a dozen to a dozen institutions across the UK who'd be interested in learning more about PSP and starting some pilot programs. Very much so. Thank you for asking.
If we were to be interested in being involved in research and possibly linking hospital, what would be the best way to do that?
Yeah, thank you for that question. So we have a national service run by the NIHR called the Research Delivery Network, RDN. It touches every part of the NHS and increasingly in the community. You will have an RDN set up in your institution and region, and it's reaching out to look at the opportunity to bring research into your care pathway. And I have to say, in my experience, it's about enthusiasm to do that, because if we don't have people that want to drive that, it tends not to happen. So ask the questions of, you know, the care teams around you, and particularly the R&D departments, because there is a portfolio of work out there that your patients are not getting access to potentially. And it is a national ambition to increase involvement of patients. The logo back there was Be Part of Research. There is a national website that's actually aimed at patients, but you can look on that website, Be Part of Research, and there's all sorts of information there that will help address your question. Thank you.
Paul, I've got a question for you if there's no other question. Oh, there's one at the back over there, so whilst you're heading towards the back, I'll ask the question. So maybe colleagues in the room may have become inspired to do their own research. I guess this is one of the NIHR is also very interested, but before you can get an NIHR grant, you have to have done a lot of groundwork first. So how would you advise those who are maybe interested? So there's that, everyone can get involved in research, and we really encourage everyone to do that. That may be recruiting patients, that may be getting involved in pilots. But what if they want to kind of start to think about, where do I start from? What would you advise as a senior investigator?
So that's a really great and important question, because we need to be more inclusive in research, because it perhaps has been a bit ivory tower in the past. I don't know what your views are, Diane. Our ambition is that this should be something, and the skills associated with research are much easier to access and develop for yourself individually and your teams. So there's various NIHR schemes. One particularly good one is the Associate PI scheme, which is open to all healthcare professionals to get involved in NIHR studies in your care setting. And you learn skills. It's free to access. It just has to be around an NIHR study. And that's a really good ground level way to get going. There's lots of other opportunities. In Manchester, we have a lot of academic training opportunities, multi-professional, that we think is really important to grow. And we do that as an ecosystem, joint community hospitals, and you know, multi-professional, which is really important. So lots of opportunity. So look locally, look at the opportunities through the NIHR Academy, which is where all the training goes on. And don't think you have to have some PhD or something to do this. This should be a basic clinical skill, in my view. It's about taking, I mean, you are all managers, you are all educators. We want you to be all researchers as well.
Yeah. If I just check, so in the room, do we have any medics? Apart from, so one or two, not many. Nurses? Okay. Allied health professionals, so physiotherapists and, okay, thank you. There are 14 professions in the allied health professions. Pharmacists? Oh, we do have some pharmacists, okay. Scientists and epidemiologists? Okay, so the reason why I asked that question is that NIHR, there are particular professions where research has not been as strongly embedded, or so to speak, and there is a strong focus now for nursing, allied health professionals, and pharmacists, and also scientists and public health, to really encourage us, and I include myself in that, to get more involved in research. So as Paul said, there are a range of opportunities. Start with your research and development group in your hospital. Otherwise, NIHR, the Research Delivery Network, or also an NIHR, each of the professions, their professional bodies were given funding to develop research training, so basic research training. So again, have a look at this. I know there is for pharmacists, so there is for allied health professions. So really encouraging you to think about that. This was not part of this conference, but Paul's talk has led us into that direction.
Thanks,
so,
Diane.
yeah.
Can I just respond to that?
Yeah.
Because I've got the mic in my hand.
Great, great. Yes, please.
I agree. I mean, I think it's really important to get all the different health specialities in research. But the problem is we're all in really busy jobs and we have very little time. And to get into research, you have to do something to start. And there's no time for that. So getting your foot in the door when you're already struggling to finish the work you've got, which is more and more and more, is really hard. So I think from the perspective of clinical staff who are on the wards all the time, finding time to start to get in is really, really hard.
Good.
So
I agree with you on that, but I started that way, being on the wards, and I think it's very difficult, and not underestimating, and things have gotten even worse now. I don't think everybody will become a specialist in research or focus, but we can all identify patients that could potentially participate in studies. So there's a continuum of research. Paul.
So
and I
Diane,
guess that comes on to the question that I wanted to ask, which is to both of you. So you've both given fantastic talks, and I absolutely agree that we can all just identify patients. My question to you both is, how do you think people should, research is still really London-centric and still recruits a lot of white male middle class, so you don't get a lot of children, you don't get neonates, you don't get people from Northumberland. How do we recruit these hard to access underserved communities?
Well, I'll go back to my slides. I think you'll see I deliberately showed you the scale of activity, which was not London-centric. It was proportionally associated with where our populations were. In my trial of 2,760 patients, we had in critical care, and we know this through the ICNARC database, representation of all the protected characteristics in the trial. And secondly, look at the distribution. I mean, this is wide scale across the UK. In fact, we did better in the Midlands and the North, so I always like coming to Birmingham, than we did in London. But there were some really good exceptions of people that supported us in London. South Coast, we could have done a bit better. There's always competing trials in this space, and I think sometimes it's about personal relationships and who you can bring on. But I would push back hard. The NIHR would not let me get away with collecting evidence in white middle-class people in South Kensington.
So I was going to, that's very true. So I agree with you in the sense of it has been like that. Things are changing, have changed. So NIHR now, you cannot submit for funding without inclusion being part of a core part of what you do. And it cannot be tokenistic. And they are funding that to make sure that people have money to be able to access that. Also, particularly when they're giving out their awards now, they are very much looking outside of London. So they're proactive in making sure that there's diversity. And that's why there's funding. Again, I've talked about nurses and allied health professionals and pharmacists. That's why there's also funding for that now. Because historically, you're right, it has been in many of the ways you've described it, but things are changing. And I think it's not going to change if those of us in the room don't act. I think we're going to have to think about whether or not it's an area of passion. It's an area of we think there's value in. And yes, we are exhausted from the clinical care, but if we don't start to get involved in research and develop the evidence base, no one will do it for us. I say that with pharmacy profession. I'm the Deputy Chief Scientist for RPS. No one's going to go and get us the pharmacy evidence that we need. So if we don't get on with it, then tough. So I think that's some of the ways we need to think about it as well. And I completely agree that life is exhausting and stressful. And not everybody needs to be fully into research, but if we all start small, we all build that evidence to support it. So hopefully we're encouraging you to...
Could I just final comment, Diane, because it is important. It's a really important question that I don't want to diminish the importance of what's just been said about protected time to do this.
Yeah.
But there is new GMC guidance which may have implications for other professions, yeah. But the new guidance is very clear that the duties of a doctor are to make sure that their patients are offered research. Now, it doesn't mean to say that they have to be the researchers, but you have to now defend at appraisal when it comes in that area. How have you done that? Because there's plenty of evidence that patients are not, don't get access to research. And because we know that patients that are entered into research overall have better healthcare outcomes, and indeed their hospitals, this could in itself be an inequality issue. So it's about making sure that we endeavour as a broad-based team to do what we can to foster the notion of engaging with research. But at the end of the day, improves patient outcomes and increases value for the taxpayer.
Yeah, and I don't think we're saying that, for this to be done without remuneration, and that's why again NIHR is really, and it's not only NIHR is not the only funding body. There's UKERA, there's several funding bodies, including charities. So if you're a specialist in cardiovascular, the cardiovascular charities will be funding research as well. So there are a range of places to get funding, so that you're not doing this on top of your work at no cost or any remuneration.